Hello, everyone. Good morning or good afternoon. Welcome to the new regional club. I'm very happy to announce that we have a new team that is managing the regional club. We have Francesca Teodonno, Alfonso Prada, Paola Ramirez from Chile, and also Jean-Baptiste de Villeneuve, Bargemont from France. I would like to thank for today Francesca and Alfonso for preparing this session, also all the speakers and Sanjeev, Kakar, who join us as moderators. So right now I will give the floor to Alfonso and Sanjeev for the Journal Club. Thank you.
Thank you, Alam, and it's good to see everybody here, and really looking forward to an engaging session with our wonderful speakers, and have the pleasure of working with Alfonso today. And we have two wonderful papers that Alfonso will help kick off, looking at DRUJ instability with distal radius fractures, and also carpal instability, scapholunate injury with distal radius fractures. What should we do with these injuries? Should we treat them? Should we not treat them? So I'm sure we'll have a great discussion, and I look forward to a wonderful time. Alfonso, over to you.
Yeah, thank you so much, Sanj, because I think this is a very, very incredible topic, because it's always unresolved how to do, and arthroscopy, I think, allows us to know how the injuries can go, or at least to know them and how to treat them as much perfect as we can. So probably I think it's a good idea to try to understand a little bit more about this topic, which, as I said, is almost unresolved yet. But I think those incredible doctors, Martina and Marta, will help us to understand a little bit more about it. So I have the pleasure to present in the beginning Marta. Marta is one of our fellowships here in Madrid, and she comes from Terrassa, Barcelona, and she is now in her 5th year of residency. And I hope you really love the presentation of Marta. Thank you, Marta.
Yeah. Okay, en la presentación. Ahí. Okay. Can you see the presentation? Okay. So first of all, I would like to thank Dr. Prada and Dr. Archina to let me participate in this journal. And as today's topic is to discuss the needs of treating ligamentous injuries in the acute setting of distal radius fractures, I'm going to present you this article that talks specifically about scapholunate injuries and the need of treating these lesions at the same time of distal radius fracture fixation. It's a meta-analysis published in the American Association for Hand Surgery in 2024 by these authors from USA. So distal radius fractures have been treated conservatively for many years, but during the last few decades, we have experienced like a shift into a more surgical treatment. And also this surgical treatment has changed from external fixations and Kirchner wires into open reduction and internal fixation with volar locking plates, which nowadays are the standard surgery. And maybe the main improvement in distal radius fracture surgery over the last years is the use of arthroscopy to assist fracture reduction and to assess articular step-offs, as you can see here in those pictures, and also to diagnose and treat associated ligamentous injuries. So scapholunate interossseous ligament, it's the most common intercarpal ligament injury after a distal radius fracture, with incidences as high as 64% or even 85% in some papers. The most common fracture types associated with scapholunate injuries are type B, which are displaced partial articular fractures, and type C, which are intra-articular fractures. And arthroscopy allows us to assess important factors that influence the surgical management of these injuries, like Geisler or Ewers classification, or the acronym SCARS. And these injuries can be reduced and temporarily stabilized with Kirchner wires, or they can be repaired using suture anchors reinforced with dorsal capsulodesis if needed. It's important because these lesions or injuries can lead to a scapholunate instability, which can lead to a slack wrist, and finally, it can progress to a wrist osteoarthritis. And despite the fact that stability of a scapholunate joint has always been thought to be because of the scapholunate interosseous ligament, now it's well known that extrinsic ligaments have a much bigger role in this stability. So the natural course of these untreated lesions is unclear. So the aim of this study was to compare patient-reported outcomes and range of movement between the operative and non-operative treatment of acute scapholunate injuries associated with distal radius fractures. This study is a meta-analysis level of evidence 1, but maybe with a lower grade of recommendation because, as you will see later, it only includes one prospective study. They search for articles from 1990 to 2021 with distal radius fractures treated with volar locking plates and concomitant scapholunate repair or fixation with a DASH score recorded and a minimum follow-up of 1 year. This is the flowchart literature. So as you can see, after a revision of 255 articles, only 3 were included for the meta-analysis, and 4 articles were included for the narrative review. And after that, they established 2 groups. And the first one is called operative scapholunate injury, which are patients with both distal radius fracture and scapholunate injury treated, with a sample size of 71. And the other one is called non-operative scapholunate injury with patients in which these scapholunate injuries was left untreated with a sample size of 57. Here you have all the bibliographic, surgical, radiographic, and functional data included. I only want to highlight how they defined scapholunate severity with a scapholunate interval higher than 2 millimeters, not present on the contralateral wrist, or a scapholunate interval higher than 3 millimeters, or a scapholunate angle higher than 70 degrees, or a Geisler injury greater than 2. So I'm going to first talk about the meta-analysis, and I've summarized in this table the main characteristics of these studies to make it more clear for all of you. The first one was published by Yoshida in 2015 in Japan. It's a retrospective study with a sample size of 15 patients and a mean age of 33, and scapholunate injury was treated with Kirchner wires. The second one was published by Duetman in 2021. From USA. It's also a retrospective study with a sample size of 34, and they treated this lesion with Kirchner wires and suture anchors. And the last one was published by Cha in 2021 in South Korea. It's the only prospective study included, and it's the biggest to largest one with a sample size of 79, and they treated these injuries with Kirchner wires. So the total amount of patients were 128, and all of them used arthroscopy to assess the degree of injuries. There were no differences between the length of postoperative immobilization between both groups, with a mean of 5 weeks, and the distribution of fracture type was also similar in both groups. So about the clinical results, first of all, 94% of these patients had a scapholunate injury grade 2 or higher, according to Geisler classification. And the final follow-up, the range of movement was similar in both groups, and there were no differences neither in the mean DASH scores. However, when analyzing the effect size, the non-treated group had a better range of movement, and the operated group had a lower DASH scores, but these results were not statistically significant, as you can see here in the forest plot. About radiographic results, only 2 studies reported scapholunate interval and scapholunate angle results postoperatively. So regarding about scapholunate interval, 2 studies found no differences between both groups. And regarding the scapholunate angle, only 1 study found a significant lower angle in the operative group, but the other one found no differences. Yoshida assessed scapholunate injuries in a second look and found that all these injuries with the Geisler 1 or 2 had healed. And about complications, they were only reported in 2 articles. The first one found 17% of a slack wrist in the operative group and 18% of second surgeries in the non-treated group, basically as STT fusion and total wrist arthrodesis. And Yoshida found a persistent scapholunate instability in Geisler 3 or 4 in the non-operative group. So finally, they did a narrative analysis with 4 studies with a lack of homogeneity for being included in this meta-analysis. As you can see, there are 2 prospective and 2 retrospective studies. And the main thing is that they include patients without scapholunate injuries, and they compare them with the operative and non-operative scapholunate disruptions. And also treatment of distal radius fracture includes not only volar locum plates, but also external fixations and Kirchner wires. As you can see, only the second study, found a statistically significance in the extension between non-operative and those one without scapholunate injuries. And about radiographic outcomes, the first study found no differences in scapholunate interval or scapholunate angle, but they did find an improvement of both in the operative group. And finally, after all, do we need to repair scapholunate injuries at the same time of distal radius fractures fixation? On one hand, these authors discuss that the potential healing of the scapholunate is better during the first 2 weeks, and that treating these lesions may prevent carpal instability. But on the other hand, injuries on scapholunate ligament alone don't produce instability, as you know, and the acute widening of the scapholunate interval has low sensitivity, as these injuries may present with normal initial X-rays, and this interval does not have a fixed limit. Also, scapholunate instability often requires a stress or dynamic X-rays for diagnosis, which may not be possible in the acute setting. And some studies show that these injuries may be repaired up to 9 months. And it seems that slack wrist only occurs in less than 10% of these untreated lesions. And in this article published by Dr. Kakar last year, it seems that the current literature shows similar results. So maybe these scapholunate injuries may not be treated on the acute treatment at the same time of distal radius fracture fixation. But however, the authors do recommend to repair grade 3 or 4 injuries with radiographic changes, especially in young active patients. So I'm sure Dr. Kakar maybe later can give us his opinion about that. The limitations of the studies that the few studies included, so the small sample size, clinical outcomes measures or scores are not consistent in all studies, and radiographic outcomes are not fully measured in all of them, and only one study has a big follow-up. Sorry, I'm hearing someone. I was saying that only one study had a follow-up of 7 years. The other ones, the follow-up is less or than 2 years. But the strength is it's a well-designed and it has a big amount of outcomes measured, and it gives us an accurate revision of all literature published until today about this topic. So my conclusions are that arthroscopy in distal radius fracture fixation allows us to improve reduction and assess these injuries. And despite it seems that the clinical outcomes are similar, the current literature supporting the repair it has a low level of evidence. So there are no large prospective randomized studies, and there are no studies including a delayed repair of scapholunate injuries, which may be also interesting to compare. And just to finish my presentation, this was a distal radius fracture that we operated yesterday by Dr. Delgado. And just to, would you leave this Geisler 3 injury without repairing it? I'm sure that the expert can discuss this later. And thank you very much. Hi.
That was amazing, Marta. You covered so much information. You did such a tremendous job in teaching us with that.
Sorry, Marta, I will just ask you to stop to share your screen so we can have the discussion now. Thank you.
So Marta, you're the world's expert now in the treatment of acute scapholunate injuries with distal radius fractures. You've reviewed all the literature, and as you've shown that the literature is level 1 evidence, right? We have prospective randomized studies of thousands of patients. No, we don't. I'm joking. So when you put that all together in your mind, obviously without telling us what was done yesterday, I think I know what Dr. Delgado did, but what would you do in your practice? When you start practice, you're seeing a patient that comes in with a distal radius fracture and a suspicion of a scapholunate ligament injury. What would you do?
I think I would find difficult or hard to not to treat these injuries if you're seeing them in the arthroscopy. So as I've said, the evidence we have is it's not based on big or large control or randomized control trials. So we have to improve the literature in order to give the patient the best treatment. But I think I would treat these injuries personally.
And would you pin? Would you do a capsulodesis arthroscopically? Would you open? What would you do?
I would use a suture anchor, I think, without Kirchner wires and a capsulodesis and an immobilization, and that's all.
Okay. Alarm, what would you do with these type of cases?
First, I will give you my opinion, but first I would like just to give you. I launched the first poll. I think the first question when we don't really do arthroscopy, or the first question is, do you systematically evaluate the scapholunate ligaments when fixing the distal radius fracture? That is the basis. And just to tell you that most of the people, 50%, only if radiographics, if the X-ray, there is a widening in these X-rays. So it's very important first to look for the scapholunate complex injury. So what I would like to say is what is highlighted in this paper is that the fixing, repairing the scapholunate complex injuries may not be necessary in most of the cases, because we have seen in this paper that I think most of the injuries were Geisler 2, if I'm not wrong, that are low-grade instabilities. Personally, I think that we should repair. I do systematically an arthroscopy following some kinds of distal radius fracture, articular fracture, young patients, high energy trauma, and for the high grade instability, I think the extrinsic ligaments distended are involved, and I do a repair. I try to stabilize from EWAS 3C. So in high-grade instability, I think there is an indication. For the in the other cases, I immobilize my patient for 3 weeks, and I think if we have a good anatomical reduction, it is enough.
Alfonso?
Yeah, I think these are different things. So we should try to diagnose if we have an acute or chronic scapholunate ligament injuries. That sometimes is a little bit difficult because we are not really sure about what is chronic and what is acute. But in the arthroscopy, we can precisely see the hemorrhagic ligament, how red or white it is, and the amount of secondary ligament stabilizers that are torn or not. So probably I think it's better to understand the type of injury we have, and also if it is related with these acute injuries, because that is something that we already know better than how to treat them or how if we need to treat or not, than try to repair everything. So if we understand the injury, probably we can give the patient the treatment that they need.
So if just sorry, Alfonso, if you understand well, you treat all the scapholunate injuries, whatever the grade of the instability.
Yeah, if we think it's acute, yeah, for sure. If we think that it's not acute, because it's not low energy fracture, or if it is probably a pattern of fracture that is not related with ligament injuries, and we think it's a whitish ligament, probably not. So we think that it's better than treat everything or not, to be in that gray situation if it's acute or if it's chronic. So if we think it's chronic, we never treat it. But if we think or suspect that it's acute, for sure, even we don't think that degree is important or not.
So apart from chondral changes that might tell you it's chronic, how else do you determine if it's acute or chronic?
Depending on the arthroscopy. So we don't care about the controls. So we think that the arthroscopy gives you a lot of information if it's acute or not, because sometimes you see a very hemorrhagic torn in the ligament and a big ligament inside the radiocarpal joint. So that it's usually related with an acute situation. If you see a torn ligament that it's very wide, non-hemorrhagic, you don't know what is the area where it's detached, and you see a lot of scar along the ligament, probably it's a chronic injury, so we don't treat it. So we rely more in the arthroscopy than in the diagnostic imaging or the other things.
Question, Francesca?
I just want to create a bit of debate, saying I don't repair acutely any SL in a distal radius fracture, and for now I didn't have any post-op instability that I had to go again and repair the SL. And I also wanted to make a point about the article. Like I chose that they try to do a meta-analysis on this topic. They use a span of 31 years, and they can only use 3 articles. Like that gives a lot on the quality of the literature on this topic. That is probably the most important problem that we need to solve to give some highlight on this on this topic.
I mean, you're absolutely right. The quality of the literature is poor at best. But also, as you said, it spanned over 31 years, and our treatments have changed. How we used to treat scapholunate ligament injuries 30 years ago to now how we've been taught by Christophe and others is a lot more minimally invasive. I tend to, Francesca, I'm more on your side. I mean, there's certain indications when I will scope a distal radius. So if I'm suspecting a type B or radial styloid, big gap, if there's impaction of the distal radius or high energy, then I'm scoping the distal radius, and then I'll look at the scapholunate interval. But otherwise, personally, for me, I get the because sometimes we don't even get contralateral wrist X-rays, right? If I would try and remember to get contralateral wrist X-rays, because sometimes the patient may have a gap on the asymptomatic side. So I think that's an important thing. And then once I fix the distal radius, I'll actually get a traction view. And if I don't see gross instability between the scaphoid and the lunate, and the alignment looks good, I will, like you, I will treat them non-operatively, and I'll follow them very carefully. And if they develop symptoms, and that Duthman study that Marta nicely referenced had patients less than 21 days, and those that were over 21 days, those were the patients that were followed, then became symptomatic, and then were treated. And as you said, the outcomes weren't any different. But we do know our treatments now are much more minimally invasive, right? So maybe we can arthroscopically do a capsulodesis. But as I said, I think the literature out there is still not known, but I think it would be good for the trainees, especially, to have a framework and work out, do they scope every distal radius and fix? Are they completely non-op? I think the middle ground is somewhere where we need to be, given what we've had. But I think wonderful discussion. But in the interest of time, I think we have another paper to discuss, if that's okay.
Maybe Alam wants to say something.
Just have a short comment.
The end of the road.
Sorry, I agree with both of you, Alfonso and Sanj. The only thing I would say is we need to be careful for the stiffness. So to try to get the optimal indication, because if we operate everything, we will add some stiffness, especially on flexion. So maybe the aim in the future will be really to have an algorithm to choose which instability and which lesion we should systematically repair. For me, it's the high grade only. Okay.
Yeah,
thank you.
Agree with that. So we will move on to the next presentation. If it's I think we are okay in time. So then, so the next presenter, it's a double pleasure for me to present Martina Archina, the second fellowship in our team. So she comes from the Hospital Gaetano Pini in Milano. Look at my Italian accent, which it was incredible. And she will talk about the most common injury in the distal radius fracture, which is the TFCC. And you will see, at least it will be the better than Marta. What do you think? No, not really. So at least good, as good as Marta. So come on, Martina.
Good morning to everyone. Thank you for inviting me and to let me present this review. I will show you my presentation. Give me a second. Can you see my presentation?
Yes.
Perfect. So good morning to everyone. Thank you, Alfonso and Alan, to organize this and propose me to talk in this amazing journal club. I'm Martina Archina, so I'm working in Milan, but actually I'm spending my time abroad here in Madrid with Dr. Pedro Delgado and colleagues. Let me present you the topic of this amazing journal club: distal radial fractures and ligamentous tears repair, to do or not to do. Francesca proposed me to talk about this review, distal radial joint instability in distal radial fractures, published on Journal of End Surgery, Asian Pacific volume by Wong et al. In December 2025. So this is my presentation overview. I will highlight the major aspects of this article through the clinical relevance of DRUJ instability after distal radial fractures, some anatomy and biomechanics, how to get the diagnosis, intraoperative evaluation, the treatment options, and then the conclusions. So why should we care about DRUJ in distal radial fractures? For sure, these radio fractures are the most common upper limb fractures, and at least up to 37% is associated with DRUJ instability. This condition is often underdiagnosed, but is the major cause of ulnar-sided wrist pain, and it can lead to forearm limitation in prone supination. We need to go over the concept that this radio fracture is just a bony problem and go through the soft tissues injuries as well. Some anatomy, so we know that DRUJ is a diarthrodal synovial joint, which it's a distal link between the distal radius and the ulna, and provides a pivot in prone supination. Since the articular recongruency of the sigmoid notch and distal ulna is not really perfect, the role of soft tissue is very important in order to guide and restrain the joint. So the primary stabilizers are the TFCC, especially the radio-ulnar ligaments and their attachment to the fovea, and in a little bit, little part, the bone congruency. For the second stabilizers, we have the extensor carpus ulnaris subsheet, the interossal membrane, especially the distal oblique band, and the pronator quadratus. Let's talk about the reason why DRUJ instability occurs after distal radio fractures. First of all, we have the ligamentous injuries, the TFCC injury, especially about the radioulnar ligaments. Then we have a basal ulnar syroid fracture or malalignment of the distal radial. For example, if we have a radial translation of the distal fragment, we have a loss of tension of the interossal membrane, and so DRUJ instability. So in the acute setting, for sure, the assessment of the DRUJ instability is very difficult, but these are the major tests: the ballotment test, the table lift test for Palmer 1B lesions, ulnar foveal sign, and for sure we have to compare with the uninjured DRUJ. Since the clinical aspect is very difficult, we need to find some radiological predictors of DRUJ instability. Here, there are the factors that I saw in the article, that is dorsal angulation more than 20 degrees, radial translation on the distal fragment, type C fractures, and DRUJ gap more than 2 millimeters, ulnar syroid-based fractures, and for sure the involvement of the sigmoid notch. This table is published on the Arthroscopic Management Distal Radius Fractures book. It's a very more specific, and I suggest to read it. But now let's talk about the treatment. It is a 3-steps process that all we should do in the operating room. First of all, fix in a proper way the distal radius, then test intraoperatively with the ballotment test, either in supination, pronation, and network position. And then if we have still the DRUJ instability, we have to treat it either with immobilization, TFCC repair, or ulnar steroid fixation. So this is the algorithm that the authors proposed, and let's go through the topic. So the most important factor is to reduce each fragment fracture in an accurate way, especially the radial translation. We know that if we have at least 2 millimeters of radial translation of the distal fragment, we can have DRUJ instability. So you can do it either with a clamp or with a spreader or with a Capanghi interfocal pinning. Another technique is the radial distraction technique, which principle is the over-lengthening of the radius in order to tight the distal oblique band and the radioulnar ligaments. And this can lead also a less loading on the ulnar side, also a less risk to develop also a ulnar impatient syndrome in the chronic phase. So the authors propose if we have a partial DRUJ instability or in supination or in pronation, we should go for just immobilization for 6 weeks of sugar tongue splinting. Then if we still have DRUJ instability with a styloid fracture, they talk about this term that is quite debated. So ulnar seal fractures occurs in approximately 50% of these radial fractures. The very, very basal ones may involve the insertion of the radial ligaments on the foveal, but evidence now show no difference in long-term outcomes in fixate or not, in fix or not fix the styloid fractures. So it's not recommended anymore. But the crucial theme is that if we have a persistent DRUJ instability, we should repair the TFCC, especially the radial ligaments at the foveal insertion. The patient regain a good wrist function, and we have a 90% of return to sport and 83% maintain long-term DRUJ instability. In this review, we can see that both open arthroscopic TFCC repair demonstrate comparable results. These are the strengths and limitations of this article for sure. The advantages are that these are comprehensive review. We have clear algorithms and practical surgical tips, but for sure it's just a level 5 evidence, expert opinion, and such a narrative review, and there's no systematic methodology. So in conclusion, in this radial fractures, it's very important assess the DRUJ instability and treat for sure the cause. The primary cause is the TFCC foveal lesion, and we need to repair either open or arthroscopic. There's no evidence anymore in fixing ulnar styloid fracture, so this is very important. And what I found that TFCC injuries is the most important ligament tear that we can see in these radial fractures, with at least 90% in arthroscopic series, with respect to the 37 that we see in this article. And then very important as the foveal lesion of TFCC. These are the primary stabilizers of these radial joints, and so they are the most clinical evidence of instability. So we need to repair this one. And for sure, here is not really clear about arthroscopy or not arthroscopy, but I want to say that for sure, wrist arthroscopy is the most accurate. First of all, in the diagnostic part of ligamentous tears, even also helping in detecting the step off, the gapping, and the fracture. But now I'm talking about TFCC, and then it's an important tool to treat and repair the lesions. These are some articles that I found really, really interesting, but there are a lot more. But I wanted to show this photo about the course, the Madrid wrist course. And thank you for listening to me. It was a pleasure.
Martina, that was an amazing presentation and review, and congratulations on an outstanding review of the topic. Just wanted to ask you before we move on to questions, how do you assess the DRUJ when you're treating a distal radius fracture? Do you examine the uninjured side first? How do you do it?
Yes, for sure. If I am doing distal radius fracture with a arthroscopic assessment, I would like to first reduce the fracture and then assess with the ballotment test. For sure, in natural supination and pronation position. If I have some doubts, I should examine the other one, the contralateral one, as I said, and as you said in your articles, for sure. But I know that it's very difficult, so you have to just rescrub again. Or you have to, if you have a colleague that can do it for you. But it's very important to compare to the other side, because for very parallax people, it's very important to see if there's a new lesion or it's just hyperlaxitude and so on.
Yeah, no, you're absolutely right. But I mean, if you look at all these wonderful people who are on the panel today, I think when we examine the DRUJ, we're all very different, right?
Yeah.
There is no standardized objective test for DRUJ instability that we can all agree on. Victor, what are your thoughts when you're managing these patients? because we all know they have a TFCC injury, or the vast majority of them do. What do you do?
Hi everyone. I couldn't go into this amazing Zoom presentation. I'm sorry for that. And we normally do what they are saying. Just try to fix first of all the fracture, and when everything of the radius is fixed, you can manage. You can figure out what's going on in the distal radial joint, and you do. Development test, you can have some doubts. That's why it's important to check the other grease before going to the operation room, go inside. That's our main idea. And when we normally use the arthroscopy, we can check just in the inner part of the joint what's going on there. We normally trust the clinical test in supination and neutral pronation, and if it's not laxity in the other hand and you feel that you don't have a stop there, you normally have to do something in the operation room. And we have to check everything because you can sometimes have some kind of stability, not always with the foveal insertion, but also with the distal part of the TFCC. So you have to manage and you have to figure out and to check everything when you are doing the arthroscopy. You can find the fovea, you can find a fovea torn, a distal torn. So you have to take care of all these structures, and they are very important for the stability.
Excellent. Alfonso?
Yeah, probably Alam can show us the results of the pool, and we can discuss about it.
I think I already showed the results of the polls. The best method to assess the DRUJ instability for the majority is the development test. I think everyone agrees intraoperatively is the easiest way to assess the DRUJ instability. And that's it. We have the last poll is now. That was the poll.
Yeah. So what I don't understand is why most of the people used to assess the radiodistal ulnar joint, but not the scapholunate ligament. So it confused me. So you need to assess the distal radioulnar joint, but not the scapholunate ligament. It's because it's in the same joint, the radiocarpal joint, or what is it about?
Well, it depends how we're assessing it, right? Are we assessing it arthroscopically, or are we assessing it clinically? I think we all agree that we assess it clinically, the DRUJ.
Yeah, but for sure. But what I mean is, if you are inside the joint, why not to assess everything?
You can. What I would ask you, and I agree with Francesca said, you can assess everything, and if you treat everything, does that change the outcome, right? And that's ultimately the ultimate goal. We have the president, Mr. Dr. Pedro Delgado, has joined us. Pedro, so good to see you.
Hi, sorry, I apologize because now I am outside from Madrid. It was so difficult to connect for this amazing webinar. Okay, about your question, okay. I completely agree with you because why not? I completely agree with Alfonso because it's very important to check it all using arthroscopy. Why? Because yes, it's very easy to check. It doesn't matter the method, okay, to the DRUJ instability, but not with a standard maneuver, the scapholunate instability using arthroscopy in this case. Why? It's very easy. For me, probably all the participants speak very well about this, but for me, it doesn't matter the small fragment of the ulnar steroid because it doesn't matter because nothing is inside, nothing is fixed in this part. Second one, if you have if you're checking the arthroscopy, you have a TFCC tear, please test the instability of the DRUJ. And you have instability, you need to repair. But you don't have instability, you don't need to repair. And of course, why not? You have a high injury tear, lesion. It's mandatory to check the scapholunate because it's not common, but probably in this case, you need to check it because it's very important because probably is the key point about the management in the postoperative period. You have extra-articular or intra-articular distal fracture, and you can see the joint inside. If there is no another tear, you may move in the first days with no problems. But if you have any tear inside, you need to immobilize at least within 2 or 3 weeks. Of course, you need to repair it. This is our test, our decision test in every distal fracture.
Thank you so much, Pedro.
Thank you, Pedro.
Yeah,
Alarm?
I think you
Yes,
the point.
Thank you, Pedro, for this comment. Hello, Pedro. Hope you're doing well. So I would like to share the poll as Alfonso asked us and to ask Pedro if you detect DRUJ instability intraoperatively after the reduced fixation, what is your first step? What is your treatment? Do you have any place anymore for temporary DRUJ pinning, for example? It is an old technique. Or
yes,
TFCC repair for everyone?
Yes, we believe in the TFCC repair. We don't like the key-wise fixation. Why? Because in fact, it's not a real repair. It's only a question of stiffness. We prefer to repair. What's the problem? Normally, you have a distal fracture. Normally, you don't have the anchors in your hospital. You're treating this type of fracture in the emergency room. But doesn't worry. Why? Because with a not foveal repair, only with a technique using inside, outside, it's an out. And then you need to immobilize with a cast with no more longer than 3 weeks with a monster cast, it's an out. The question is, we need to repair. It doesn't matter a foveal fixation, and you need to immobilize within 3 weeks with no pinning. This is our proposal.
So if I understand well, you repair only the foveal disinsertion, the peripheral tear, no. The superficial peripheral tear, no. Only normally, the foveal disinsertion.
Yes, because normally if you have a peripheral tear, it's not easy or it's not normal to have to check instability of the DRUJ.
Yep.
Thank you.
So if we want to add a little bit more fight to this journal, maybe we can ask Carlos. Carlos, are you here about your opinion on the repair of the TFCC in the distal radius fracture? Because I think he will give us a little bit of fight on that topic. Carlos, are you here? I think it's a little bit. And Francesca.
I think you're gonna fight after my literature review.
Sure.
Yeah.
So, and Jean-Baptiste, are you with us?
I think.
What do you think about it?
I think it's a multifactorial situation, and it's a multifactorial decision. I think I have the same vision than Professor Pedro Delgado, but when you have DRUJ instability, it will depend a lot of factors. If you have a big ulnar silhouette fracture with the TFCC footprint, you need to just fix the ulnar fracture, and most often the case, it's fix the DRUJ instability. But when you have DRUJ instability in distal radius fracture, not all of the DRUJ will become unstable. So there is a lot of multifactorial. If you have a big sagittal deformity at the preoperative X-ray, as a huge translation, it means you have maybe a distal oblique bundle injury and associated with a TFCC injury. So we have to find some algorithm because I think it's multifactorial, and I think if you have a peripheral TFCC lesion, you don't need to perform surgery, but you have to know that there is a TFCC injury, and you have to put some immobilization just to begin healing of the ligamentous structure. And in my practice, when I have a DRUJ instability, I have no surgical factor for perform a surgery. I just perform a conservative treatment, and in most often of the case, we achieve a stability DRUJ. So we have to find some factor to choose surgery or not. But you have to know if you have TFCC peripheral lesion or not.
Yep, totally agree with you.
Yeah, it's a great great discussion. I think Victor has his hand up. Victor? Still on mute there, Victor.
All right.
There you go.
Yeah.
Victor, we're having some connectivity issues there.
I have a question. Part of the last. Can you hear me now?
Where are you, Victor?
Now, I'm here.
Yeah.
Can you hear me?
Yes.
Yes.
So I was late in the last presentation, so I have some doubts combining both presentations. So when you talk about just treating or not treating these kind of injuries, the TFCC or the scapholunate injury, you mean that you see it and you leave it and you start moving from the first time, or you just put...
Sorry, Victor. We're
I think Victor is in cave.
Leave it for 2-3 weeks.
So I think the question is, Victor, without trying to speak for you, is that if you see the injury and you don't fix it, how do you treat them? So I think
this is different. It's not
the
same to repair.
I think it's a little bit difficult.
I think Martina had a great point in that these injuries are soft tissue injuries with a broken bone. And I think if they do have a soft tissue injury, I think the treatment is very different to then just fixing a distal radius fracture. So a couple of points that I wanted to point out. Martina showed how important correcting the radial translation of the distal fragment is, which is absolutely. I would give you one caveat. Some of us put the laminar spreader between the radius and the ulna to push the radius radially. Be careful. I have seen people really push hard, and they push so hard they can avulse the TFCC off the distal ulnus. You have to be careful of that. I remember many years ago when I had the privilege of coming to Madrid, listening to all of our colleagues here, and also Paco, who said something that sort of resonated, that when you examine the DRUJ after fixing the distal radius fracture, if it feels unstable, and then you radially translate the wrist and then check it, if it then stabilizes up, the secondary stabilizers are intact. So for those, I will treat non-operatively in an above elbow splint to protect pronosupination. But otherwise, if they're still unstable, then personally, I will fix it. But I must admit, I don't fix a lot of acute TFCC injuries with distal radius fractures unless they're grossly unstable. So I think the discussion point is amazing because we all want the same outcomes, but we all come from it with different angles, which is amazing.
Yeah.
I'm sorry. I was
Victor, sorry. We need to move to the lecture of Francesca because we are running a little bit out of time. Sorry. And so Francesca, go on with the end of the session. Sorry, Victor, but we are running out of time.
Okay, can you see my screen?
Yeah, we can see it.
Okay, so first of all, of course, I would like to thank Alan for the opportunity of doing this Wrist Journal Club. And I would like to congratulate my colleagues from IWC Madrid for the amazing work done. So I'll be doing a small literature review, and these are going to be the main points that we're going to follow. So to be frank, when we chose this topic, I thought it was going to be easier. I was not expecting in finding myself in a jungle of heterogenic literature in PubMed and Cochrane. And at some point doing this review, it felt like a mission impossible to achieve. So in the literature, there is an increase of incidence of intra-articular distal radius fracture, especially in the economically active population. This led to an increase of surgeries, with or without arthroscopy. And this also led in the literature of an increase of ligamentous lesions in the wrist, which is a diagnosis of ligamentous lesion in the wrist, which is the problem that we face today. So what do we need to do with them? So let's start with, and these are some hard truths that we need to take into account. Distal radius fracture pattern that is predictive of a ligamentous lesion. The only pattern that is predictive is the ulnar styloid fracture for the TFCC injuries. The real incidence of ligamentous injuries is complicated to obtain because sometimes, as we spoke about it before, it's very hard to differentiate, even arthroscopically, an acute lesion to a chronic lesion. So these are the most three common ligamentous injuries, and let's start with the TFCC. So the estimated incidence in the articles, as you see, it's very high. We can even conclude that 1 out of 2 distal radius fractures have a TFCC injuries. In the studies, the Palmer classification is the most used, and the most common lesion encountered is the 1B, which is the peripheral tear, and much less frequently, the foveal detachment, which is of course linked with the DRUJ instability. So how do I suspect a TFCC lesion in a distal radius fracture, hence need an arthroscopic evaluation of it? Of course, in very gross disruptions of the DRUJ, very gross deformations, and in a clinically unstable DRUJ after distal radius fixation. So the point the point on this topic is the DRUJ, which is why we chose the article for Martina. Overall, we can conclude that if the DRUJ is stable after fixation, there is no need to treat the TFCC. And if it is unstable, like on the X-ray that you see on the right, we do need to treat, but I could not find any study that could tell me if it's better to pin it, to put a suture anchor, to do a transosseous foveal reattachment, or to even do conservative treatment. And why is that? Because a lot of studies don't have control group. There's a lot of, as we said before, heterogeneity of techniques used for repair. And in some studies, the follow-up is very, very low. So overall, I think we can conclude that if you have a stable DRUJ, there is no need to acutely repair the TFCC. If we have an unstable DRUJ after distal radius fracture fixation, there is no superiority of techniques. I would like to point out a very interesting article that basically followed untreated traumatic TFCC tears in a very long span, so like 15 years. And they had a total of 43 patients, and they only needed to operate one after the distal radius fracture fixation because of an unstable DRUJ. So it's true that unstable DRUJ leads to less grip strength, but overall, the clinical outcomes are not that bad. So second most lesion ligament is the scapholunate ligament. The incidence here is also very, very variable. On this topic, we do have a lot of literature, but there is first heterogeneities in the classification used. Some study use the Geisler, some study use EWAS, some study use Dotel. And there's also a lot of heterogeneity on the techniques used. It's true that the most common lesion encountered is, let's call them the partial low grade, so the Geisler 1-2 lesion. And again, when do I need to perform an arthroscopic evaluation in the setting of a distal radius fractures? Because I think the SL ligament could be injured. So, of course, the admitted parameters are the styloid fractures, the intraarticular step-off, if you have a die punch fragment, if you have a sagittal just on the SL, and also if you have an intercarpal space widening. And a special mention to the high energy trauma, especially in young patients, because they could hide incomplete greater arc injuries. So which one do we need to treat? It has been confirmed in studies and in a lot of meta-analysis that you need to treat the plane injuries. You need to treat the incomplete greater arc injuries, because if you don't treatment, you have less strength and overall worse clinical outcomes and overall more risk of arthritis post-op. But why supposedly we don't need to treat the low-grade injuries, so the grade 1 or the grade 2? We need to think in the SCARS acronym. In the low-grade injuries, the vascularization is intact, the secondary stabilizers are intact. So that means that they will probably heal, and if they don't heal, this will not produce in the future a clinical instability. So about this topic, I didn't find a lot of studies that compare different types of technique. We don't know if Pedro technique is better than Christophe technique or it's better than pinning. We have no idea. What do we know is that we need to treat the high-grade injuries, because usually are part of an incomplete arc injuries or plane injuries, but there is no consensus on the grade 3 injuries, and there's a lot of debate on that. So what where do I think the problem could be? So there are a lot of articles in which they compare, for example, pinning with conservative treatment. And what is the conservative treatment that they use? Sometimes it's in one study, for example, it's a long arm cast for 4 weeks. Why would you immobilize the elbow in a scapholunate ligament injury for 4 weeks? It makes, in my opinion, no sense. Or in other studies, also the conservative treatment was only 4 weeks of a cast. So maybe there is a little bias that we could elucidate with better studies. And the third most frequently injured ligament is the lunotriquetral ligament. Of course, the real incidence is much lower, and this injury is rarely isolated. We usually find it associated with partial TFCC injuries, partial scapholunate injuries. And when do we need to perform an arthroscopic evaluation? So when we have a high energy trauma, because we are basically we have the suspicion that it could be a plane injury or an incomplete greater arch greater arc injuries. So the point is that in the distal radius fracture, this sequence, the famous Mayfield sequence, the plane sequence, it's rarely incomplete because the fracture dissipates the energy before. So this is why it's very rare to find an isolated LT tear. We usually find the lunotriquetral tear associated with other lesion, but not all of them progress into a full perilunate instability. So the problem is that we don't know a lot about the natural history of untreated, isolated LT injuries. So the conclusion is that when you have an LT injury, it's usually associated to other injuries, and if it's a high-grade one, you should treat it. So I wanted to finish this review about some food for thought, as the Americans would call it. And I think in stuff that we can improve as hand surgeon to elucidate a bit more this topic. So for example, I think in the topic of the TFCC, it is interesting to study if there is like a clinical difference in treating, for example, with a suture anchor or with just pinning the DRUJ. For example, for the scapholunate topic, we could maybe compare like a proper conservative treatment with maximum to repair techniques like ADCLR or bone anchor. And in lunotriquetral, we need to know more about the natural history of isolated LC tears. But overall, we do need better quality studies. We do need more precise studies, and also studies with the control groups. So this is my conclusion for, I think today in 2026, overall, we don't need to repair the ligamentous tears unless it is a high-grade injury. So thank you very much for your attention.
Thank you so much, Francesca. It was an amazing presentation, but I cannot agree with.
Maybe Alfonso, you can. Francesca, could you please stop to share your screen? Maybe Alfonso, you can conclude the webinar and tell us just to sum up when to do or not to do, when for the DRUJ and for the scapholunate for you.
Well, no, in fact, I totally agree with Francesca. There's no evidence that we need to treat this kind of injuries, because I think we have no evidence in hand surgery at all. So probably it depends on the experience of the surgeons. Sometimes we see on arthroscopy very big injuries that are not related of what we see in some journals or some articles that we for sure we need to treat. So the arthroscopy for all the attendants allow us to understand the injuries and to have information about the injury. So, for example, what Victor said before, at least we have to treat them. So if we had a TFCC injury or a scapholunate ligament injury and we don't know how to treat them arthroscopically, we can add some more immobilization, or we can add some more time, as Sanj said before, to see the patients properly during the time. So the follow-up is very important in that kind of injuries. So probably I think, as Francesca and Sanj and Dr. Kakar said, it's something in between. We don't have to treat everything. So in my case, we suggest you to treat big gross instability injuries on the TFCC. So if you have, like Jean-Baptiste said before, if you have a gross instability in the TFCC, in the distal radioulnar joint, we have to treat it, at least arthroscopically, open, or above the elbow cast to stop pronosupination. And in scapholunate ligament injuries, it's a little bit different in our case. So we think that probably in most acute injuries, grade 3A, 3B, 3C was, and grade 4, we need to do something. If you have time to do arthroscopic repair, or probably like Vicente's technique or capsulodesis, it's okay. But if you want to immobilize, it's okay too. Or maybe put some K-wires, but you have to do something. So to sum up, I think this is probably the best way nowadays in 2026, as Francesca said, to treat this kind of injuries. But probably we have a lack of information today. So because arthroscopy is evolving, and so that's why we have to do this kind of journals.
Thank you, Alfonso. I think it's a good summary of everything we had said before. We have Efrain Mendoza Banuelos. He wants to send a case. I think to have a point of view. I think he can send the case to both of you, Alfonso or Francesca.
Yeah, sure.
So thank you, Alfonso. Thank you, Francesca, Marta, Martina, everyone, for preparing the Journal Club. Do you agree, Alfonso and Francesca? We can conclude and we can finish the Journal Club. Thank you to everyone. And the next appointment is in, I think, 2 or 3 weeks for the IWC symposium. And we will have, of course, another Journal Club in 1 to 2 months with our great team here. Thank you, everyone.
Yeah. Bye.
Thank you. Thank you so much for joining.
Thank you. Thank you.
Thank you, everyone.
Have a nice day.
Have a nice day too.